I've been looking forward to our next talk all day. When we first put together the first summit, one of as we had put the agenda in place, one of the things that became very obvious, actually I was talking to Michael Rim over there at the time about the structure of the agenda. And he had just recently run into Barbara Perry. And he says, I was talking to Barbara about this. And she said, well, what are they doing about retiree health care? What are they saying about it? And of course, I had a blank look on my face because it is always really the elephant in the room when it comes to retirement and retirement planning. If your health isn't good, certainly the quality of your retirement is going to be diminished. If your health care costs are very high, the quality of your retirement is diminished. And Patrick, I was talking to one of your colleagues about retiree health costs, and he said to me, ultimately, it's hard to keep costs down if you've got sick people. The most important thing is to be healthy. If you're healthy, costs are necessarily going to be lower. So this is an interesting topic. It's a subject that's important to me, and I'm really glad we have the opportunity to talk about it. I'm going to start at my far right, and then I'll work my way closer in. Barbara Perry, I have known Barbara for a long time. Barbara was my boss early in my career at TIA Craft, where she was responsible for Michigan, Indiana, and Ohio. She was there for 22 years. She held various national and regional senior management positions, including vice president for public retirement markets and covering the public K through 12 and government sectors, and regional vice president, managing multiple offices and teams of relationship managers and individual consultants who are dedicated to serving educational institutions in the Midwest. And she has a broad background and expertise in retirement plan design. And I know this to be quite true, because I learned so much from her. Retiree health care benefits and related employee health benefits, especially in the higher education area. She graduated with honors from Fairleigh Dickinson University with a bachelor's degree in Spanish and Russian area studies. And she attended University of Costa Rica as an undergrad, and she did graduate study here in D.C. at Georgetown and also up at NYU. We're also really privileged to have Patrick O'Brien. He is the head of Retiree Solutions and Shared Administration for Aetna, Inc. He also heads up Aetna's public and labor segment. In this role, he's responsible for really driving the strategy to attain all retiree new business sales goals, as well as for the retention and service of Aetna's $3.8 billion existing book of retiree business. He's a 29-year veteran of the health insurance, healthcare industry with really a deep knowledge of the public and labor market. He came to Aetna from United Healthcare. So we didn't overlap because he works now in the building that I worked in at Aetna at one point, but we did not overlap. He received his JD degree from DePaul University and has a BA in history from Providence College. He lives in Rhode Island. That's a commute. With his wife and 3 kids and Labrador Retriever. So we want to start with Patrick. Thanks so much, and we look forward to hearing you.
All right, Keith, thank you very much. Also, thank you very much for the invitation to be here. Okay. All right. Thank you, Keith.
Thanks.
Thank you for the kind words, and thank you for the invitation to be here. Now, one of the things that I heard kind of talking about earlier this morning, earlier this afternoon, was kind of like the long-term sustainability of Social Security and other entitlement programs. I'm going to go through some slides. I'm going to try to go through them quickly, and what I'm going to really try to do is tee up from a macro sense some challenges that are in front of us, and it's all Americans, not just my company or whatever. It's challenges that we're all going to have to grapple with, decisions that are probably going to be made. Then I'm going to get a little bit more granular, and I'm going to talk about challenges and things that can be done today to allow for sustainability going forward. So that's my plan. But first, I'm probably going to be covering some information here that many folks have seen in one shape or form. But basically, entitlement programs consume almost half of the federal budget. I think folks know that. What people might not have spent time on is understanding that health care accounts basically for a good percentage of that as well. Medicare is 14.4% of that. Medicaid and CHIP is another 7.9. So health care is already a huge expenditure for the government. Now, over 40% of U.S. health spending was paid for by public programs. That's what we were just referring to. And you know, that compares to about 48% with private insurance. Now, where am I going with this? Sometimes people say, you know, Obamacare or whatever it is, I don't like the government getting involved in health care. The government has always been involved in health care. Not only that, the U.S. government has been the largest claims payer in history for probably the last 25 years. Okay, now I'm going to start getting it. This is my first baby boomer slide. There's a couple of these coming. All right, so health spending is projected to increase at a dramatic rate as the baby boomers retire. One of the things I like about this slide is no matter, I don't care, I happen to be a liberal arts major, but trying to quantify what this is really doing, look at the left. That's in billions, 5,000 billions. And if you look at the right with the baby boomers entering Medicare, that shows you that the spending is going off the charts. There's just no way to underclub that. And as a society, we're going to have to come to grips with this. There are going to be decisions that have to be made. Okay, so now here's a pretty busy slide, but I'll point out a couple data points here. It's my second baby boomer slide. The influx of the baby boomer generation is going to double Medicare enrollment over the next 20 years. So what does that really do to stress the system? We hit about 50 million enrollees in Medicare in 2012. By 2030, that's going to jump to about 81 million. And there's a famous stat that many people have heard, but for the next 20 years, 10,000 baby boomers turn 65 every day. We'll be up over 100 million Medicare members as we start pushing out towards 2060, 2070. Now, what's the crux of that? Really, where is that driving it? And there was the question today about Social Security. This number is more based on Medicare, but by 2030, there will only be 2 workers for every 1 Medicare beneficiary, as compared to, it was 4 to 1 in the 80s. Okay, so I'm here to talk about fragmentation in healthcare and things that can be done to try to make it sustainable. But right now, Medicare, Part A anyways, is paid for by payroll taxes. Now, something's going to have to change. There are going to be decisions, and again, I heard, we said on the earlier panel, there are going to be decisions that just can't be kicked down the road. This is what's facing us. Okay, so that was kind of a big picture. It's kind of daunting. But now I'm going to start looking at other things here that actually is systemic that we can deal with. We can start really making a dent and moving the needle in a positive direction on all this spend. According to the Institute of Medicine, these, by the way, have not been Aetna slides. These have been general industry slides. Unnecessary and inefficient waste contributes to about $765 billion in annual waste. At the bottom here, we say inadequate care coordination and care management contributes about 25 to 45 billion of that. So what this is really saying, no one wants to hear that billions of dollars are being wasted, but if we could be more efficient, if we could be more effective, if we could coordinate care better, there's a huge pickup to be had here. Now again, here's another stat that might be a little bit mind-blowing if you really drill into it. We've all heard about the 80-20 rule. We think that maybe 20% of anything contributes 80%. Whether it's your employees that cause issues, whether it's your kids, whether it's like 80-20. That doesn't necessarily happen in Medicare. The stats bear it out. Over half of Medicare fee-for-service spending is concentrated in the top 10% of beneficiaries. But if you drill into that more, 1% actually drives 15% of all the spend, and about 9% drives about 37% spend. Do the math. Now, why am I putting this out there? What if there was a way to get to these people that are driving the spend earlier? What if we were able to put in programs that can impact their health, discover who they are, engage them, and allow better outcomes here? Would not only improve quality of care, it would save dollars. Okay, I'm kind of wrapping up these individual stats here, but about 70% of Medicare fee-for-service beneficiaries have 2 or more chronic conditions. And as people grow older, the probability of having multiple chronic conditions are things that don't go away, that have to be managed. It increases with age. So about 23% of Medicare beneficiaries actually have 4 to 5 chronic conditions. So if you've got grandparents, if you've got parents, if you've dealt with older folks, they're dealing with multiple doctors, multiple providers, multiple prescriptions. Is healthcare through the fee-for-service side of Medicare being delivered in a coordinated manner? The answer is no. Now, kind of moving on, cardiovascular conditions are often comorbid and difficult to manage. About 55% of all beneficiaries with these conditions have 5 or more chronic health conditions. So what it's saying is, again, to coordinate care, to work with individuals that are sick in the senior post-65 population, there's room for pickup here. There's room to do a better job. Now, a third of Medicare beneficiaries are readmitted to a hospital within 90 days. What does that mean? Maybe they should not have been released anyways. What if there were programs in place to allow them to stay home? What if there were ways to manage folks after they get out of the hospital better? And care during the last year of life represents about 25% of total Medicare spending. Now think about that. What if there were programs in place to work with folks? Information comes back consistently that most people would rather have quality of life than prolonged life. People would also rather die at home. That's not what happens in the United States today. Okay, so now where am I going with all this? On the left, you have Medicare Part A and B, and on the right, you have private plans, also known as Medicare Advantage, and Part D, MAPD plans. The way Medicare works, Medicare was never intended to cover everything. It's not like an employer-sponsored active plan where you have like a deductible and an out-of-pocket, and you might even have an annual max. Medicare is scheduled. Part A helps with hospital costs. Part B covers outpatient and doctor costs. But they don't cover everything. Many people with original Medicare, that's what it's called, also choose supplement plans. So now think about it. You're an 86-year-old individual. You've got Part A, you've got Part B, you've got a sup plan. Maybe you're not in the best of health. You're getting hit with bills. You're trying to coordinate this. You've got multiple physicians. It just is a fragmented, ineffectual way to care for the population. On the right, you have Medicare Advantage. That is what our lead product is at Aetna, and not just Aetna, but in the private sector, like other companies like United Healthcare, Aetna. We offer what's called Medicare Advantage programs. It pulls all the parts together, and what it does is it lets things like care coordination and population management be brought to bear. There are levers that you can pull in order to increase outcomes and save dollars. And by the way, Medicare Advantage plans, by far and away, have higher satisfaction rates than original Medicare. So better care leads to healthier results. If you have a large plan-sponsored group with the Medicare Advantage program, you can actually drop in a care management model. And you know what? Clear it all away. I could bring a clinician in here that could go on for days about the analytics that can be brought to bear in order to basically do Moneyball on a population and understand outcomes and affect better results. But really, it comes down to four things. How do you find those people? How do you find the 1% out there driving the 15% of cost? How do you engage them? People that have chronic conditions, multiple chronic conditions, and let them coordinate their care better. How do you help them? And how do you improve outcomes? So that's what private carriers do with a care management model. And the stats I'm about to show you are actually our own book of business compared to original Medicare. This isn't meant to be an Aetna commercial, but all I'm showing is just empirical evidence. It's what I had available to me. But when we compare our book of business, 350,000 plus, actually all of that's just the public and labor segment. It's really over 500,000 if you look at all Aetna. We have 24% less ER visits, and we have 31% fewer hospital acute care days compared to Medicare fee-for-service in our programs. It's huge, and I'm going to show you what that means from a bottom line further down. So first, a care management program can be brought to bear that can really assist outcomes, and it provides it's just a more effective use of the system. Another lever that can be pulled here, you hear about provider collaboration and networks, and it's a buzzword right now, ACOs. It's a collaborative operation between maybe carriers like us and providers, and they absolutely work. And this is a new model, not an HMO. People say, oh, I've seen that before. You're going to send me to a particular provider, and I can't go anyplace else. That's not necessarily true. If you compare them, what we're really bringing to bear now is earlier identification of at-risk patients, enhanced patient engagement, and first and foremost, we're changing up how providers are actually compensated for care. The old way of looking at things, providers were paid contingent upon volume of service. The sicker people were, the more money they made. By working in collaboration, you can put together a payment model that actually pays providers for cost and quality. And it works, and I'm going to show you some evidence of that shortly. So these are some savings achieved. If you look around, and again, we're not the only one, Aetna's not the only one doing this, but I have some empirical data here. But we have an ACO collaboration agreement with Inova Health in Northern Virginia. This isn't just Medicare stats. This is all our business that runs through there. We show that we have 45% fewer hospital admits than compared to the norm, book of business norm, and 56% fewer readmits. We have about 250 ACOs. We have about 120 operational, and we have about 250 in development across the country. Again, it's another lever that can be pulled to rein in cost spending and improve outcomes. Now, something else here. There's some headwinds in front of Medicare Advantage. And when we talk about quality, one of the things that always used to happen was people say, okay, how do you define quality? And every carrier would say, well, quality is this or quality, and they'd be slightly different. Or they'd be different. There'd be a pattern, but they weren't exactly the same. Well, CMS has solved that problem in the retiree area because they have what's called the STARS rating methodology. And it's predicated on quality outcomes, operational incentives, operational excellence, and member satisfaction. And what CMS does to companies, organizations like mine, is they assign you a star rating. Now, why is this important? Because if you make the cut with a certain level of star ratings, you're eligible for a bonus. The margins in this business are thin. You rely on that bonus in order to run your business. Next year in 2015, the bar has been raised. organizations like mine were eligible for a bonus if you had achieved 3.5 stars. That's going up to 4.0. Again, I don't want this to be an Aetna commercial, but we have achieved 4.5 stars in our national network. So we will be in line to retain that bonus, which is critical to running our business. However, there's a little box over here that shows 48% of Medicare Advantage enrollment are in plans that will not attain that 4.0 lever going forward. There are other headwinds against Medicare Advantage. Medicare Advantage expenditures are being used to defray costs for the ACA. So they've been reducing reimbursements to carriers. So Medicare Advantage is kind of under pressure, but we still think it's just by far a better model than original Medicare. I was going to go into private exchange solutions. I think, if there are some questions after this, I'm happy to do that, and we can kind of talk about that. But I kind of wanted to make sure that Barbara here has an opportunity to actually weigh in on some of the things that I've been discussing. But I wanted to end with 3 empirical objective case studies. And this is one of our customers. It is a Northeastern public sector plan sponsor. It's actually a state. And we're an offering within their retiree population. We don't have the whole thing. We cover about 10,000 retirees. But we know that since they awarded us their business and converted to Medicare Advantage over the last 3 years, we have saved that population in excess of $8.2 million. And we gave them equal to or better benefits. It's actually a better benefit design than original Medicare. Here's a second case, real-life example. We have a retirement system in the Midwest where we have about 61,000 retirees. Over 3 years since they converted to Medicare Advantage with us, we have saved that system over $118 million. And again, they actually have better benefits if you compared it to original Medicare. And they get better healthy outcomes, which is the driving point here, and they're actually more satisfaction with their own plans at the member level. And then last, I'm going to give you also a Midwestern labor union group with about 7,500 eligibles, 6,700 enrolled, and we know that over the first year we saved that group $8 million. Again, with equal to and or better benefits. It was not a reduction in benefits that drove this. It was the care management model that I was referring to. So with that, Barbara, I think I'll turn this over to you.
Thank you, Patrick. Having technical difficulty. Well, while we're figuring that out, I will just, once again, say I'm Barbara Perry, and I work with the Retiree Retirement Health Solutions Organization. We're a non-for-profit that works with not-for-profit educational groups on retiree health care products. I'm not going to talk about the products, but I am going to talk about why I might have been selected as the cleanup batter. Because in a way, I hope to kind of pull together a little bit of our whole subject matter regarding retirement planning and retirement readiness. And I think the message here is that when we talk about the effects of retiree health on the American dream, we've been talking all day today about how to get people engaged in retirement planning, how to get them to save, how to think about how they can take personal responsibility and fashion a life for themselves, no matter what community you happen to belong to. And I think one of the things that we have seen over the years is that financial planning has always been geared to how do you create assets to rely on to create a stream of income, to pay for overall income needs in retirement. Or, in the case of defined benefit retirement plans, how can you create that stream of income from your employer pension plan? What has been lacking to some degree is the integration of retiree health care expenses into that overall retirement planning. And that's really what I wanted to talk a little bit more about today, picking up on some of the points that Patrick was making as well. So when we talk about security in retirement, it means different things to different people. Certainly having enough income to live on, certainly having access to affordable health care, maybe being able to maintain your lifestyle or travel or spend time with family. Some people start another career. I invite you to think about your own retirement dreams. Fill in the blank there about what's important to you. Maybe it's trying to live that dream of living better than your parents lived in retirement, or maybe even just as well as they're living in retirement, because certainly the next generation has their work cut out for them. But more than that, it's really looking at what are the components of that retirement security. Income security is one part of it. We've been talking a lot about that today and how some of us are a lot further away from that than others. But the healthcare piece is a big part of that. And when I talk about healthcare security, what I'm really talking about is not just access to affordable healthcare and talking about the kinds of programs that Patrick was talking about, but also protection against catastrophic expenses, because there's no quicker way of depleting all of your savings and all of your retirement assets than a catastrophic healthcare event, unless you have some kind of protection. And that usually means some kind of insurance that has some out-of-pocket limits so that you're not going to go bankrupt just to pay a healthcare bill. And as Patrick was saying, there's a lot of things that need to be taken into account when it comes to looking at retiree health care expenses. Why is it such a big deal? Well, because most people aren't really educated enough to know about what exactly are they going to be on the hook for when they reach retirement. We talked about Medicare Parts A and B, and Patrick mentioned that Medicare Part A helps you pay for some of your hospital expenses. Part B helps for some of your doctor's expenses. You did pay for Medicare Part A through your payroll taxes, at least up to this point that's how it's worked so far, but Medicare Part B is not just through payroll taxes, there's a premium to pay in retirement. Everyone who's on Social Security and starts enrolling in Medicare Part B has a deduction out of their Social Security check, and that deduction starts at about $105 a month in 2014. And it's actually indexed to income, so higher income earners are going to pay multiples of that number for Medicare Part B premiums. And then there are deductibles and other co-insurance. Patrick mentioned that Medicare was never designed to do the whole trick anyway. In fact, it's only been designed to pay for roughly 60% of total health care expenses. I don't know about you, but I wouldn't want to go get a hip replacement and still have to pay for 40% of the bill. It's certainly going to be important for us to have protection above and beyond Medicare. And then, of course, Medicare Part D is the prescription drug part of Medicare that does require someone to actually enroll in a plan and pay that premium, which also, by the way, has some income-related surcharges attached to it. So if you're thinking about the basics of Medicare, traditional Medicare, or even assigning over your Medicare Parts A and B benefits over to a Medicare Part C plan, a Medicare Advantage plan like Patrick was talking about, we're still talking about multiple levels of out-of-pocket expenses in retirement that have not quite been factored into that overall retirement planning. So even supplemental premiums and copays and deductibles and coinsurance are going to be important. But what about the things Medicare does not pay for and that maybe not even are insured under your supplemental plan? Dental care, vision, hearing, long-term care. These are all other expenses that have to be factored into overall health care security in retirement. So I know I use this slide because a lot of people just at this point of the day are like pulling their hair out anyway, right? You've heard enough about this and all the woes that we face if we're not planning adequately for our retirement. But in the workplace, there's also a lot of other confusion going on. If you are fortunate enough to be employed by an employer that provides some kind of retirement and health care benefits, there's a lot changing in that equation of what is the employer commitment to health care in retirement. So there are such things as defined benefit promises that were made. If you reach retirement age and you retire from this employer, in the past there used to be sometimes a benefit that allowed you to see a portion of your premium being picked up by your employer. Those are old defined benefit promises, we called them. The problem with that was they were never funded. They created unfunded liabilities. And in fact, those liabilities are now having to be reflected on financial statements, whether you're a private employer or a public employer. You have to reflect what is the value of those future promises to pay. These unfunded liabilities are unsustainable. And as a result, employers have really started to walk away from these kinds of retiree health care benefits. It's been coming for a long time in the corporate world. It's spilling over into the nonprofit world, and it's also affecting the public sector these days, again, because of that unsustainable trajectory of promises for supporting health care benefits. So instead, what you're hearing about a lot is, let's turn to the defined contribution solution. Well, certainly on the retirement side, we know we've been making that transition from defined benefit to defined contribution retirement plans for quite a long time. And so too will we begin to make that transition into a defined contribution approach for health care benefits, sometimes in active employment and then also even in retirement. But there are some terms that are being bandied about that are getting a little blurred in the marketplace. So for example, you might be hearing, well, let's go with the defined contribution approach. We'll just say, here's a fixed amount of money and go buy your own insurance and have fun while you're doing it. That's a fixed contribution. That's still a future promise to pay. That's still not being funded anywhere. There's no money being set aside for that. That's still creating unfunded liabilities, and that may or may not be the ultimate solution. It does cap the promise. It does cap the liability, but it doesn't make it go away. You may also hear the term a true defined contribution approach to retiree health. What that means is very much like it has meant for the 401k and the 403b plans that you're all familiar with, that you actually have an account set aside. You have dollars going into that account during the working years, but they're being separated out. And the purpose is simply to be able to pay for health care expenses in retirement. There are different funding vehicles for this, and depending on whether you're corporate or for-profit or not-for-profit, there may be different tax advantages to these different funding vehicles, like VEBAs or different kinds of trusts. But there are dollars set aside sometimes in this defined contribution approach that will be available as a pool of assets that are segregated for just health care expenses, if in fact that's what your employer is able to do. And then, of course, there's really the sources of retiree health benefits. The sources being insurance in the public marketplaces that came about as a result of the Affordable Care Act, or in private exchanges as well. So we're going to talk just a little bit about that. When it comes to these perspectives about what do you do about retiree health care benefits, I'm really looking at it from two different perspectives. First, from an individual perspective. If we thought that we weren't going to have enough money saved to live on in retirement, what do you think about the lack of savings that people have for retiree health care in retirement? If anything stops you from retiring, it's because you can't continue access to your employer-provided health benefits. This situation that's being set up right now, and this is true of just about all sectors, is that there are people delaying retirement just to hold on to access to employer-provided benefits for health care. And that actually has an impact both on the individual, who may be delaying their ability to move on to another chapter of their lives, but also for employers, because it may actually impact the way they want to renew their workforce, because timely retirements help open up new jobs for new generations and new ideas. And so that's an impact that employers have to think about. And then, on the other hand, employers are actually beginning to look at this whole value proposition of providing employer-provided health care benefits to begin with. None of us really want to see that go away entirely. In fact, if anything, it really helps to spur a conversation about what is the social contract between an employer and its employees. Certainly, people want to be attracted to a particular position. Employers want to retain good performers. They want to continue to reward people in long service. And so part of the question for employers is, what is the value of continuing to provide that employer-based benefit? One size does not fit all, and certainly every institution, every organization has to decide what are they going to do to step up to the plate to to balance the resources that they pay for attracting employees, as well as those resources that they allocate to those that are moving into retirement. So we really have to think a little bit more about that. I mentioned the different terms of defined contribution plans and fixed contribution arrangements. Retiree health benefits in the public sector are still pretty much in place, but they're being really challenged because of the affordability factor. So you're going to see a little bit more movement towards these fixed or defined contribution approaches. What's really different for retirees is that for the first time, the public marketplaces are going to allow some access to individual insurance plans for retirees up to age 65. Post 65, you've got Medicare and you've got other kinds of arrangements like Medicare Advantage plans or supplemental plans. But overall, individuals have to first of all look at what is their employer providing them and whether they're going to have access to any group insurance plans from their employer or whether they're going to have to look outside into the exchange market. So for pre-65 retirees, there are going to be these choices of going into the public marketplace. It's really the first time that they won't have to worry about pre-existing conditions. They won't have to worry about whether their employer is actually going to make plans available, but they'll have to decide what they can afford through that individual marketplace. But only up to 65, because post 65, it really does depend on what your employer is going to do for you. First of all, to know whether you have access to a plan at all, even if you have to pay for it yourself. Secondly, whether you have the ability to shop on the individual marketplace for a plan. We had individuals in earlier panels that were represented here from AARP. Certainly that's a source for individual plans. And some employers are turning to private marketplaces or private exchanges as well, which also offer both pre and post 65 plans, usually individual plans, not group plans, and usually they offer some kind of administrative services that go along with that. One caution I want to throw out there, and it's something that is part of the education process, is that when an individual who is post 65 goes into the individual marketplace, or even through some of these private exchanges through their employer, these individual plans are not necessarily ones that will come with all the same flexibilities as group insurance had. So for example, if you have somebody retiring at age 65 and they go into a Medicare Advantage plan, yes, they will be able to switch among Medicare Advantage plans without any worries about their health conditions changing. But if they go into an individual Medicare supplemental plan, you might have heard the term Medigap plans. These are government-related plans, A through N. They will have guaranteed access the first time around. But in retirement, if their health needs change, if they want to switch among those individual Medigap plans, they will be subject to medical underwriting. They will be asked health questions. They may be rejected outright, or they may have to pay a lot more for that insurance because they've had other health conditions evolve over the course of retirement. That's different from group insurance plans. Group insurance plans still have what I call lifetime guaranteed issue and the ability in some situations, if there's multiple choices, to change your mind every year. And that's part of what we were talking about earlier too, that if you were to move into retirement in a healthier condition, then isn't it nice not to have to buy the Rolls-Royce plan if you can get away with the Chevrolet for a while and have the ability to change your mind later on when you need to upgrade your coverage. So these are some of the issues and the questions that have to be part and parcel of that education process when it comes to retirement planning and overall integration of health care into retirement planning. So we talked about the options for post-65 coverage. I think we already did that. That some of the group insurance plans that people have are tied to those defined contribution arrangements. That would be nice if an institution could or an organization could find themselves doing that. This way they give people the ability to have access to some assets to pay for health care as well as ongoing access to group insurance plans. So we talked about defined contribution plans. Why are they trending? Well, first of all, people can't afford the old way. They can't afford those future promises to pay, and individuals are being told that they have to take on more and more of the responsibility to save for themselves. Part of our mission, I think, here today in talking about overall retirement planning is to help people understand and quantify what are they going to need for health care in retirement, and to identify not only the pieces of the puzzle, but also how much is that puzzle going to cost. And it will change over time, there's no doubt, because medical trends change and demographic needs change and longevity needs come into place. But I think we're going to see that more and more people need to be more educated about this. So taking on more responsibility and also having plan sponsors perhaps look at their commitment to their employees both in active service and retirement is what we're thinking about looking at. And I'll just give you one series of numbers to chew on just as we finish up this these prepared remarks, and that is the Employee Benefit Research Institute here in Washington does a survey and periodically updates this to actually quantify how much do people really need to pay for out-of-pocket health care expenses in retirement. These numbers can be pretty sobering and a little scary to people, no doubt, but they really come out of good research about what are the costs of Medicare Part B premiums, what are the costs of an average Medicare Part D prescription drug plan, what are the average costs of the supplemental plan to Medicare, and what are the average utilizations of those drug expenses in retirement. There are three different factors that that are variables here. One is, are you a high prescription drug user in terms of your health care conditions? Are you going to be able to use the median amount of drugs, maybe one or two chronic conditions, chronic prescriptions, or are you going to end up being a higher prescription drug user? So depending on the level of expenses in retirement, you might need more money. And also another variable is, if you have money set aside for retirement and you didn't realize how much you were going to need for health care, how much risk do you want to take about being able to support yourself through an average life expectancy in retirement when it comes to health care expenses? Do you want to say, I'm okay if I'm 50-50, or do I want to make sure I'm in the 90th percentile of not running out of money for health care expenses? The other factor that changes is gender, because as we heard earlier in the discussions today, certainly we do know that women still have longer life expectancies than men, and therefore they may need their assets to last a lot longer. So the sobering numbers are that if you're in a couple, let's say an age 65 couple today, depending on how risky you are about running out of assets or how much you anticipate in prescription drug use, you could be looking at between $220,000 and $360,000 worth of lifetime expenses that are not covered by Medicare. And that's a real sobering number for a lot of people. So I know that's kind of scary, and what we end up trying to do with people in our education process is say, let's break it down. Let's break it down to a yearly budget, a monthly budget. Forget about these big numbers in the overall 30 years of retirement, but let's break it down into what you're going to be expecting to pay for Medicare premiums, a supplemental premium, and Medicare out-of-pocket expenses. So these are all part and parcel of the education process, and I hope it's giving you a little food for thought and perhaps some ideas about some of the questions you might have to pose to us as a panel. Thank you.
I realized that, and I saw my tent there, and I thought, well, I can't sit there now, especially since there's
There's another chair there.
When you look at the numbers, it makes me long for the GM days or wherever where you had health care for life. And to tell you a story, my father has been very sick this past year, and he was in a coma for months, and then he was in as a result of infections and kidney stuff. I mean, every health problem you can kind of check off the box, it seems. But he was in the hospital for months, and then the facility to get him off the ventilator, and then the rehab, and people commonly say, well, how much did that cost? What's going on? He was in the hospital for 6 months, and much of it in acute, intense type situations. And the answer is, well, I don't know, probably, not that much, because he had, retiree health care, and they're at GM, and their benefits that they don't provide to new hires now. He was there for almost 40 years. And, which sort of leads to the question, how much will retiree health care actually cost in retirement? I mean, what do we foresee? What I do know is that for them, I guess they came along at a good time. They were in that right demographic bubble. But where are we headed?
I'll comment, maybe
Yeah.
Patrick will comment too. Other than these big numbers we just saw as estimates from EBRI, we can definitely look at individuals' current situations right now, and this is not related to income. Unlike everything else, healthcare is very egalitarian. We don't have a choice as to saying, well, I'm going to spend just a certain percentage of my income on healthcare. Everyone has an equal chance of being well or an equal chance of becoming sick. So the dollars we talk about are really constant dollars for everybody, no matter what your socioeconomic status happens to be. And so if we just break it down into just dollars and cents, we know that today $105 a month right off the bat is Medicare Part B premium. On average, a Medicare Part D prescription drug plan is at least $40 a month. So add that up for another 12 months. Supplemental health plan or even Medicare Advantage plan, it depends on where you live and your geographic location. Sometimes that'll be a function of the premium. Also, your level of coverage will be a function of premium. But you can easily add another $200 to $300 a month for supplemental health care expenses. And then that's not counting long-term care. Let's not even begin to talk about long-term care. That is another issue that unless you qualify for Medicaid, you will not have covered under Medicare. And so, we're talking about $4,000 to $6,000 a year per person without getting really sick. Because if you were sick, then you'd have to pay the $1,100 Medicare Part A deductible, and you'd have to pay all of those other deductibles and copays that come under your supplemental plan. Hopefully, you pick a plan that has an out-of-pocket limit so that you have that catastrophic protection. But so even on an annual basis, $4,000 to $6,000 is minimum in terms of what health care costs are going to be, just for an average person with not really getting that sick during the year.
Patrick, you're nodding.
I'm nodding. I mean, I'm trying to say, it's a great question, and we get asked it a lot. And Barbara just gave a really concise summary of costs that we know about, and she's right on the money there. Another part of this question, though, is what about costs we don't know about? I mean, one of the things driving healthcare costs is people are living longer, and we keep coming out with more therapies and more procedures and more things that can be done to help people live a longer life. And I mean, that's just kind of part and parcel. These things come at a cost. I mean, if you look at my parents' generation, someone with a cancer diagnosis, they wouldn't even talk about it. They looked at it as a death sentence. You look around right now, there are so many people that have gone through cancer, and every family's been touched by it, and you might not even know it. People are just dealing with these things, and like medical technology has done amazing things. It's remarkable, but it does come at a cost.
Now, we're grappling with this as individuals, but companies grapple with it too as they provide retirement plans for their employees. How should a plan sponsor evaluate a retiree employee benefit plan? You know, we're hearing a lot these days about how plan sponsors are deciding to eliminate retiree benefits for this group or that group. I'll start with you, Pat, and then
Sure. I mean, there's a couple things there. It depends on the nature of the plan sponsor first. For better or for worse, in the area that I focus on, public and labor, oftentimes they're obligated to provide benefits. So even if the county administrator would love nothing better than to whack the benefits to try to balance the books, they're obligated to provide it. And if you're going the Medicare Advantage route, there are things that you look at. First of all, I do believe it's a better model for all the reasons that we put out there, and it has empirically proven better results. And you look at the STARS rating of your plan for long-term sustainability. That would be the first thing and foremost. Second, in the commercial world, many large plan sponsors are going the defined contribution route. They're saying we'll go to the individual, we'll set up a site similar to a 401k. We'll load it with individual products, just like when you go in, figure out where your allocations are going, your 401k, and we'll let retirees buy these individual products. The thing that Barbara really pointed out there is there are issues there. Like more than 60% of the people that go to exchanges for retiree health end up with a sub plan. And at the end of the day, just Barbara was talking about, there can be issues with supplements. They can work for many people, but not for all. It's not a one size. There are things down the road where you can have medical evidence if you try to switch out or things like that. So, I think, Keith, that, again, it's one of those things where there's not necessarily an easy answer, but the plan sponsor has to step back and say, what are my goals? What am I really trying to solve for? What are my long-term obligations? And how do I best get there? Also, if you go to all individual products, you lose the ability to do population management, which ultimately is the lever that can control cost.
And I would agree with Patrick, too, because the promotion of wellness during employment and after retirement is ultimately going to sustain all of us in a better way. One of the other things that I think is a strategic issue for employers is to also look at the overall demographics of their employee population. Because as Keith said, there are certainly whole cohorts of individuals who've been hired after that line was drawn in the sand and said, no more for you, versus their colleagues who are a little closer to retirement who might benefit from far richer benefits. So you create a whole population of haves and have-nots. There is some issue there to deal with, sort of an employee relations issue. But beyond that, even from just looking from the employer standpoint, if you have people that are continuing to work beyond their most productive years, hanging on and hanging on and hanging on, just in order to have access to active employee benefits, then you're going to have some opportunity cost. You're going to have maybe not as much productivity or creativity or benefits of the experience of that workforce as they age. I mean, they're going to be very helpful with all their experience for quite a long time, but at some point that will diminish. And in that sense, you're also reducing the possibility of bringing in new generations of individuals with different skill sets, with the ability to respond more to the changing marketplace, to new technologies and new research. So there's a whole opportunity cost for not having a timely and dignified retirement available to individuals. And that's from the employer perspective. And of course, from the employee's perspective, you want to be able to move into retirement in a dignified way and have access and affordable health care and know that you're not going to go bankrupt with your first health care event. So there's that strategic value, I think, that needs to be looked at as well.
When you were given the talk, it seems that you're talking about large employers. I'm not even thinking about the small companies. I'm thinking that even medium companies are not providing this type of benefits. Do you have a sense of, by number of employees, where is the cutoff kind of companies with less than X employees are really not providing any of this? And once you have that cutoff, what's the alternative for all the others that work for, let's say, medium and smaller companies, independent, et cetera?
Sure, I can take a run. Well, historically, larger companies had provided retiree benefits. That's been a trend that has been dropping over the course of the last 25 years. And I mean, just like a GM and Keystad. But retiree benefits were oftentimes part and parcel of working for corporate America. That trend has been going down. Now, medium companies, say about 100 to, 1,000 employees, many of those did provide retiree benefits, or they provided it for a certain cohort, or they raised the bar really high about how you could actually become eligible, how long you had to work, stuff like that, before you were eligible for retiree benefits. Smaller companies typically did not. I mean, some of them might have, but they typically did not. Barbara, you might actually be, in terms of the individual market, you might actually be probably better positioned to respond to.
Sure, I'll make a comment on one particular industry first of all, and then I'll talk a little bit about the individual marketplace. Since I work so much in the higher educational marketplace, it's been a little bit different in that marketplace. And for those of you who are familiar with that, if corporate America used to provide retiree health care benefits, and now they're down to less than 20% provide retiree health care benefits, it was the other way around in higher education for a long time. about 2/3 of higher education institutions actually provided some kind of retiree health benefit, even if it was just access to a plan that you pay for yourself versus some kind of subsidized plan. That's going down steadily, just as corporate America is too. So what that really means is that employers, even small employers, might still be able to provide some kind of access to a benefit through these private exchanges. It's just they have to go with their eyes open as to how the individual products that are being offered under those private exchanges will actually work for people. And then as individuals, if there's no employer-sponsored benefit whatsoever, with or without any support, then there are still individual products in the marketplace. And certainly, AARP and other companies, Aetna, all of these large insurance companies do have individual products, Medicare Advantage plans, as well as those Medicare supplemental plans. So there are going to be places to go to find the insurance, even if you don't have an employer sponsorship of any kind. It's just a matter of being able to be a little more educated about how they work and what's best for you. There are some resources to go to. The Medicare.gov site does give you some ability to go and shop for different kinds of plans that are available in your particular location. I know AARP and other companies would also have that ability for you to do some shopping. Actually, small employers wouldn't have to pay much to provide this kind of private exchange opportunity, because oftentimes what happens is the private exchange doesn't charge a per participant fee to the employer. They simply make their money off of the commissions on the insurance products themselves. And therefore, they can say, well, here we are, we're going to offer you this program. You can go and shop through this private exchange for some products, and they're not really having to pay much money for it. So it's a kind of an easy way, in some ways, for a smaller employer in particular to do that, although larger employers are going down that road too. It's just a matter of having the consumer educated about what does that individual product mean, what does it cost, what's the benefit of that product.
You may have just answered my question, but I thought if you could speak briefly to the reentry into the workforce of baby boomers and other retirees, and if you could also talk about outside of education and labor and public sectors, if you could talk about self-employed, for example. And lastly, could you say if your data is available on your website? Thank you.
Sure. Do you want to start, Patrick?
Yeah, I mean, again, outside of public, of plan sponsored, I think that was kind of like the individual market that Barbara was just kind of covering. There are products and services available. It's a competitor, but AARP is great. Go to it. That's what they're all about. Now, they use United Healthcare behind the scenes. People don't know that.
Right.
But before you just do that, there are ways to go out and compare and to shop. This whole idea of private exchanges coming up. Again, healthcare is going to that model similar to 401k. If you were around in the 80s, and there used to be investment professionals that would say people will never invest on their own. We need people like me to do that, guys in suits. It turned overnight. And look at everybody, like we have Schwab's or Fidelity's. That is happening with healthcare. That will be an empowering thing for the self-employed and small businesses as well. And again, the thing is, you have to understand what the consequences are, just like in finance when we were talking about investment. People are going to have to educate themselves on the downstream impact of choosing a particular product and what it might mean and how it might impact them at renewal.
And you do still have the public exchanges, let's say that too, for self-employed, unemployed, small businesses as well. So you have the public exchanges for active employees and individuals up to age 65. It's just it's not going to do anything for you after age 65. So then you still have to go and look for individual companies' products or some other source of that. But I really do think that even the unemployed would have an opportunity, the self-employed would have an opportunity to look at these offerings that are not going to cost the company any money, but at least give access to these plans for their retirees to pay on their own. And sometimes they set up enrollment and billing procedures that are pretty streamlined, so it doesn't add administrative burden either.
So employers can actually sponsor a group plan without even contributing to it.
Right,
That's the bottom, and
exactly. Oh, yes. Certainly the slides that we showed today are certainly
I mean-
available on the
Yeah.
American Retirement Initiative website today, and if there's any other questions, you can, and because my contact information is there, you can always contact me directly as well.
Yeah.
same
yeah,
here,
we'll
we
have
can
that
make
up.
it available.
Right.
No. One of the things I think companies have been very good about is, well, sometimes, very good about is helping employees plan their distribution options from their retirement plan. How do you think they can better integrate their retiree health care benefits into the overall conversation?
First of all, I think it's all a part of education of employees. We talked earlier today about doing workplace meetings to help people understand what their benefits are, what their personal investment choices would be. Same thing with healthcare. Help people understand what's available to them while they're actively employed, what's available to them when they're retired. Do they have access to a plan or not? Will they have to go shop on their own? And then introduce information like we've been talking about today about what is their responsibility going to be. It's a shared responsibility. Medicare is only going to be covering some of the cost, and you'll, as an individual, need to be looking at your supplemental benefits or your Medicare Advantage costs or other out-of-pocket costs. So education is a part of it. And also, I think the dollars and cents, helping people actually do a budget. Let's sit down and do a budget for people. Let's say, what are your basic essential needs, and how are you going to cover that from the savings that you've put together, your retirement plans, and let's factor in those specific costs that we know are givens, the things that we know about. We don't know about all the uncertain healthcare costs, but the certain costs that we do know about, factor that into your income needs. There are statistics that show, studies that show that probably up to a quarter of our income will be spent on out-of-pocket healthcare expenses, and that's without a catastrophic event. So that's sort of a normal thing to be building into your budgets in retirement.
Keith, I echo all that sentiment. And you know what, I also look at the parallels between the financial planning conversations that went on earlier too. For individuals and small companies, there are advisors out there that you can talk to, independent third parties. I would also make sure many of them do work on commission. So you just want to make sure what's motivating the individual to make the right choice for you.
And maybe the financial advisors need some educating as well on healthcare, so that they can make it a component of their conversation and not an afterthought.
That's a good point. That's a very good point.
Again, my name is Beatrice Johnson. I'm with New York Life, and my background is retirement plans. And I want to know if you had any stats on the retirement health savings accounts that some employers are offering, and then the stats you have on how many of them are being offered and how that will pan out in the new cafeteria plans that may be offered.
I can tell you a little bit about some sources that we can go to, and a little bit about HSAs versus other retirement savings vehicles. HSAs, for those of you who aren't familiar, health savings accounts, must be tied to a high deductible health care plan. They're typically used with organizations for active employees, and because they're high deductible plans, a lot of times the contributions that go into those health savings accounts by either the employer or the employee or both tend to be used up during the active years. You know, if you have a family member get sick or your child breaks a leg, you're going to start using the dollars in that health savings account. It's a good vehicle to build up dollars for out-of-pocket expenses while you're in active service. It's not a particularly efficient vehicle for building up assets for retiree health care expenses. A, because there are limits on the contributions you can put in. B, because you tend to use them up while you're actively employed. And C, because you can no longer continue making contributions to those accounts after you stop working, where you can continue to build up assets. Having said that, they're still a good vehicle for building up some tax-advantaged assets. There are other retiree health savings programs that are a little bit different than that. The average HSA has about $2,300 in it, and that's probably just enough, not even enough, to cover a family deductible in one of these high deductible plans. So typically it's going to be used up. I can point you to the Employee Benefit Research Institute ebre.org. They actually have a paper on health savings accounts and what percentage of employers are going down that road. It's actually an EBRI issue from January of this year, so that would be a good source to give you the statistics about how many employers are using HSAs. But it's not an either-or situation. You could use HSAs and you could offer other kinds of defined contribution vehicles to set aside retiree health assets that are segregated but are going to be available for future use in retirement.
Thank you.
Sure.
Listen, I want to thank both of you, both Pat and Barbara. This has been a really good conversation for a lot of us, I think. If we come at it from the financial assets, defined contribution accumulation side, healthcare just seems so complex to us. So this is really helpful. This is really good information. So I want to thank you both for being here, and thanks for for contributing. We get a lot out of it.